Hi, my name is Dr. Omyema Ogbuagu. I'm an associate professor of medicine in the section of infectious diseases at Yale School of Medicine. Today, I'm going to be presenting on HIV pre-exposure prophylaxis as part of the Connecticut Infectious Disease Society educational series. I think this is a very timely presentation, especially as there's been renewed focus on HIV prevention to address the unacceptably high number of incident cases that occur every year. I hope at the end of this presentation, learners will be able to define HIV pre-exposure prophylaxis and elucidate its role in HIV prevention. Also, I'd like to give pointers on what I consider to be a patient-centered HIV prevention counseling approach, which helps providers identify opportunities for HIV prevention for individuals who engage in activities that put them at risk for HIV infection. I will also put in some slides here around current opportunities and challenges with implementation of PrEP and what are the emerging disparities in PrEP uptake that should provide incentive for providers to be able to expand the reach of PrEP to the communities that they serve. So I think let's start by talking about HIV epidemiology, and this will provide an opportunity for us to think about why HIV prevention is important. I'll start by showing trends of HIV incidence in the United States, and I think it's really important as we look at a 6-year time frame to examine how incidence trends have changed over time, and hopefully this then informs why HIV prevention is important. Now, I broke down these slides to show the estimated HIV incidence among people who are greater than the age of 13 in the United States. And in the next few slides, we'll be breaking down the incidence by age, by gender, and by HIV risk factor. So if you take a look at this slide with the horizontal axis showing the 6-year time period between 2010 and 2015, and on the vertical axis, the estimated HIV incidence in thousands, it's pretty clear that while there have been essentially declines among the youngest individuals aged 13 to 24, there are disturbing trends which include an increasing HIV incidence among individuals who fall within the 25 to 34 years age range. But it's important to show that the youngest individuals, reproductive age individuals, are still disproportionately impacted by HIV incidence. As you can see that the lines of incidence are way above those, for example, who are 35 to 44 years and those 45 to 54 years. So therefore, I think there's an increasing recognition that younger individuals are being disproportionately impacted by HIV in the contemporary years. Now, let's look at this incidence trends a little differently. When we break down these incidence trends by race and ethnicity over the same time frame, again, like is recognized in the HIV community and public health workers, are that minority communities remain disproportionately impacted by HIV. So it's clear that Black and African American individuals and those who identify as Hispanic and Latino, when compared to the relative proportions of the US population, are disproportionately impacted by the HIV epidemic. In fact, there was a slight uptick for Hispanic Latino individuals between the years 2010 to 2015. Similarly, when we look at the incidence trends by HIV transmission category, men who have sex with men or individuals who engage in male-to-male sexual contact are by far disproportionately impacted by HIV in our communities. And as you can see here, there's actually been a flatlining of the incidence trends over the 6 years, suggesting that incidence trends continue to remain at the same levels over time. This is not the case with heterosexual individuals who have experienced a slight decline over the same time period. So just to put this all together, it's clear that incident infections are occurring disproportionately among individuals who engage in male-to-male sexual contact. And among that group, individuals who fall within the younger age groups, 13 to 24 and 25 to 34, are disproportionately impacted. And similarly, across racial and ethnic lines, Blacks and Hispanics are disproportionately affected. We have seen declines in the contribution of injection drug use to HIV incidence, and also declines in heterosexual transmissions that occur through heterosexual contact. So these incidence trends are bring to our mind the importance of recognizing individuals who engage in these risk behaviors to be targeted for prevention prior to acquiring these new HIV infections. Now, I'm going to show you a very compelling slide. So this was CDC data, where they present what they have calculated to be the lifetime risk of acquiring HIV infection that's categorized by HIV risk factor, gender, and racial ethnicity lines. So this slide shows the lifetime risk of acquiring HIV infection, for example, for men who have sex with men is as high as 1 in 6. And we know that breaking it down by race and ethnicity, for a black man who has sex with men, the lifetime risk is about 1 in 2. For Hispanic or Latino men who have sex with men, the risk is about 1 in 4 acquiring HIV in their lifetime. For women who inject drugs, the estimate is that 1 in 23 will acquire HIV in their lifetime, and you can see the data for heterosexual women and heterosexual men, with heterosexual women having a slightly higher risk of acquiring HIV in their lifetime in the United States. These are very concerning statistics and data, and I think that these are what compel us to really put emphasis on optimizing modalities, discovering new ways to impact HIV incidence within these vulnerable communities and individuals. Now, here's also just going to show the same data, just a different way, broken down by race and ethnicity, as we previously mentioned. And for African American men, the lifetime risk of acquiring HIV is about 1 in 20, and the number drops for African American women and Hispanic men, about 1 in 48. But again, if you look very carefully at the top left-hand image, you can clearly see that minority communities are disproportionately impacted by HIV in the United States. And so that when we think about the interventions that currently exist for HIV prevention, the focus should certainly be in those risk groups. I also included a figure in the right bottom side of your screen, which shows the numbers specifically categorized by race and ethnicity for men who have sex with men, showing that the lifetime risk among minority men who have sex with men are really high. So I just want to spend a few seconds to discuss on why minority young men who have sex with men are disproportionately at risk for HIV. I'm not going to read through all these bullet points, but just to highlight a few. For young men who have sex with men have been shown in studies to misperceive their risk for HIV infection. So these are individuals who engage in HIV risk behaviors but do not self-recognize that those behaviors put them at risk for HIV. We do recognize the alcohol and drug use field risk behaviors that exist within MSM communities. There's the phenomenon of chemsex, where substance use goes alongside with risky sexual behaviors, including having multiple sexual partners, having binge sex, less utilization of HIV prevention strategies, which can all increase the risk of HIV infection. And there's also the issue around the prevalence of HIV among sexual networks for men who have sex with men, such that the high prevalence in those communities also contributes to the disproportionately high risk among individuals who are new entrants or new participants in sexual networks. And I'm sure most of us know about the structural barriers that exist for minority communities accessing health care and prevention services. So let's talk about pre-exposure prophylaxis. So what is pre-exposure prophylaxis? HIV pre-exposure prophylaxis. HIV pre-exposure prophylaxis is when an uninfected person who engages in behaviors that put them at risk for HIV medications, HIV infections, takes antiretroviral medications. So the medication that we currently have available, the only approved medication by the Food and Drug Administration, is tenofovir, disoproxil fumarate, and M3-cytidine. These are two nucleoside reverse transcriptase inhibitors that are co-formulated in a single tablet. This combination was approved by the FDA in 2012 for the indication of pre-exposure prophylaxis. against HIV infection. And the CDC released guidelines to inform the implementation of HIV pre-exposure prophylaxis in routine clinical settings in 2014, and serves as a great blueprint and a resource for providers as to how to carry out this important biomedical prevention approach within their clinics. Now, it's important to mention that for the clinical trials that led to the approval of tenofovir and emtricitabine combination therapy for prevention of HIV, that the studies did not include PrEP as a standalone intervention. The studies included standard of care approaches which are typically utilized for HIV prevention, which include counseling around behavior modification, such as using condoms or barrier methods that can decrease the risk of HIV infection, but also that individuals are encouraged to decrease their risky sexual partners, such as decreasing the number of sexual partners that they engage in, utilizing condoms more frequently, and things along those lines. And also, individuals who were exposed to HIV were also offered post-exposure prophylaxis, non-occupational post-exposure prophylaxis, as is typically conducted within HIV prevention clinics. So the point here is that PrEP should be a part of a comprehensive HIV prevention package and not a standalone procedure. This image shows some of those interventions that have been are evidence-based that can result in decreased number of HIV infections. And this includes, for those at risk for HIV infection, behavior modification, as we've previously discussed, pre-exposure prophylaxis, which we're going to discuss more, and also post-exposure prophylaxis. So here is a summary of the PrEP clinical trials that have been performed to date. This is a very busy table, but I'll try to deconstruct it. So on the left-hand column, this describes the various clinical trials that have been performed for HIV PrEP. In red are the HIV risk groups that were studied for those individual studies or group of studies, and the locations of the studies are listed in parentheses. In the middle portion of this figure, you see the point estimate of PrEP effectiveness in a circle, with a 95% confidence interval being the horizontal bar. And you can see designations of 0, meaning no effectiveness compared to standard of care. On the left-hand side, you have a minus scale, and on the right-hand side, you have 100% effectiveness. Most of the studies fall within these parameters. And on the rightmost hand column, you see the effectiveness. To summarize this table, HIV PrEP has been shown to be effective in all HIV risk groups. This includes individuals who are in serodifferent relationships, men who have sex with men, heterosexual men and women, people who inject drugs, and in women. However, you will note that the effectiveness percentages are relatively lower, and in some cases even in the negative range, showing diminished effectiveness of PrEP compared to standard of care among women. And the most important factor that contributed to this was the levels of poor adherence that occurred using the PrEP medications among women. This is critically important. So this does not reflect the lack of effectiveness of PrEP among women, but really goes to show that adherence is a critical component of effectiveness of pre-exposure prophylaxis. Put simply, if you don't take the pill, it doesn't work for you and it doesn't prevent HIV infection. So to summarize these studies, PrEP is effective among all HIV risk groups. The poor efficacy among at-risk women, as been previously mentioned, is due to the low rates of adherence in the clinical trials. An important point that has been raised also are biologic differences that can contribute to lower levels of the medications in the vaginal microenvironment. For example, a group has shown that women with bacterial vaginosis who had a higher bacterial burden in the vaginal microenvironment tended to degrade the medications more locally in the vaginal environment. So there are certain biologic reasons why tenofovir and emtricitabine may not be as effective. However, we think that the principal driver of lack of effectiveness may be due to poor adherence. There still remains limited data on adolescents and pregnant women. However, there have been demonstration projects, including here in the US, on adolescents' use of pre-exposure prophylaxis, and it has recently received an indication for use among adolescents based on a study showing effectiveness and lack of significant harms, including impact on bone mineral density among adolescents. However, the data remains very limited, and caution needs to exercise within this risk groups of young individuals. Now, one other way PrEP is utilized. So most of the data that was shown on the previous slide has shown PrEP used as a single pill once a day continuously for HIV prevention. However, there are concerns about the need for daily use of medications, and if there are strategies where we can still achieve effectiveness in HIV prevention but limit the exposure to medications, and thereby improving adherence and possibly reducing side effects of the medications. So a team, the IPAGAY group, came up with an event-driven intermittent HIV pre-exposure prophylaxis, which included a loading dose of tenofovir and emtricitabine, 2 tablets taken 2 to 24 hours pre-coitally, and a tablet taken 24 hours and another one taking a tablet afterwards, 2 days afterwards. So put together, these were 4 tablets, 2 taking before intercourse and 2 taking after intercourse around the event, a sexual event. And they found that individuals who engaged in this study had high retention rates of about 85%. Now, this study showed that there was an 86% relative risk reduction for those who utilized the on-demand intermittent pre-exposure prophylaxis compared to those who were standard of care. And interestingly, this effect size mirrors what has been described in clinical trials for the daily used pre-exposure prophylaxis. So the on-demand PrEP also represents an effective strategy for HIV prevention. And if I might add, that this strategy is more likely to be effective in individuals who do not have sex as frequently, because studies have shown that for individuals who have intercourse more frequently, using the on-demand PrEP strategy, it eventually translates to taking medications almost every day regardless, and therefore it makes sense that staying on a daily pill would be a much more effective strategy for these individuals. There remains growing evidence that this strategy could work. However, there are concerns among the scientific community about the ability to maintain protective drug levels, especially at sites where HIV is deposited, including the male and female genitalia, and also how individuals who engage in unplanned sexual encounters may not have been able to take a loading dose as this strategy implied. Similarly, this approach has only been studied among men who have sex with men, and so its efficacy in other risk groups, especially women, considering some of the biologic differences that occur with drug levels with emtricitabine and tenofovir in the female genital mucosal environment, are serious concerns, which is why this strategy has not been recommended in the United States for routine use by the CDC. But the advantages are clear that using less pills could lead to improved adherence. Their retention rates were high, as we previously demonstrated, and the possibility that there are less long-term toxicities from the lack of daily use of the prevention medications. Now, let's talk a little bit about what are the real-world observations around PrEP implementation, and then we would round up the presentation with giving you pointers as how to implement pre-exposure prophylaxis in your clinics. So I thought it was important to share with you some real-world observations so that it's clear that even with the early implementation and rollout of PrEP, that it's becoming to be identified that there are certain risk groups that are not being reached as well as others. So here's a slide from the Fenway group in Boston. And what they did was they looked at a cohort of 5,857 patients who did not have HIV infection but had an indication for screening for a rectal STI in their health center. So these are individuals who had a reason to be screened for a rectal STI, which suggests that they engaged in HIV risk behaviors. Some of the good news from this slide, looking both at the top and the bottom figure, is that when you look at from 2012 to 2016, it's heartening to see that there was an increased uptake or utilization of PrEP among all individuals in that clinic who met their eligibility criteria. And this was across racial and ethnic profiles as well as age profiles. However, when you looked very closely at the rates of utilizing PrEP among these risk groups, looking at the top figure, you can see that Black individuals and Asian and Pacific Islanders among their patient populations tend to be engaged less on PrEP than white and Hispanic individuals. When we look at the different ages, broken down by those who were less than 25 years of age. The next group was 25 to 34 years of age, then 35 to 44 years, and 45 years of age. It's clear that the youngest individuals who were less than 25 years of age were also less likely to utilize PrEP. So these are very interesting data. Granted that this is a single center, and we definitely need more data from other risk groups, but there are early indicators that even among widespread swath of clinics and based on nationwide numbers, that minorities and younger individuals tend to be engaged less in HIV pre-exposure prophylaxis clinics. And this causes pause as to the differences between the engagement in PrEP and what we now know about the disparate incidence of HIV. So it appears that the individuals where HIV incidence is disproportionately occurring, and including minority individuals and young individuals, that they also tend to utilize PrEP services less. So there's so much more work to be done to engage these risk groups in HIV prevention strategies. Now, another study looked at the PrEP coverage among racial and ethnicity groups, but looked at it by region of the country. So broken down by the states in the Northeast, those in the Northwest, those in the south of the US, and the West. And the goal here was to see which regions experience greater disparities in racial and ethnic coverage for PrEP. And so the numerator for the study was the number of persons prescribed Truvada for PrEP, as gleaned from databases, and they had about race ethnicity data for about 2/3 of this patient population, and the denominator was the number of persons with indications for PrEP based on CDC data. And what you find is that across all regions, the Northeast to the South to the West and Midwest, again, you see those racial ethnic disparities persist across the entire swath of the United States, where Black and Hispanic individuals are proportionally underrepresented in HIV prevention programs. And so this really highlights the gap in HIV prevention services among individuals who meet these demographic definitions. I wouldn't talk too much about this slide, but there's also disparities by region in PrEP prescriptions. And so this was a great abstract presented that looked at the PrEP to need ratio, and this was subsequently published. But this goes to show that if you use the new HIV diagnosis occurring across the United States as a proxy for the need of HIV prevention, and you match that against the number of people who have received active PrEP prescriptions. And actually in this study, they described active PrEP prescriptions as those utilizing PrEP for at least 1 day. So in my mind, this represents even probably an overestimation of PrEP use, as we know that individuals can start on PrEP and discontinue PrEP along the way. But regardless of those caveats, it's interesting to see that those with the lowest PrEP to need ratio, suggesting that the utilization of PrEP is so poor, predominates in the southern part of the United States, where you see a lot of red. And, based on what we know about HIV incidence, where we recognize that a lot of new HIV infections are occurring in the South, as well as more than 50% of people living with HIV also living in the South, you recognize that there's a mismatch between sites where HIV is occurring and sites where HIV prevention services are robust. This, again, is a very concerning observation. Similar things have been shown when you look at what they called PrEP deserts, which represent distances between individuals who need PrEP based on their risk profile and where PrEP is being offered. And so here they described drive times from where these individuals live to where there are established HIV prevention services. And in the darker maroon and red area, these are individuals who need to travel at least an hour, 30 minutes, or 2 hours from where they live to the nearest PrEP provider. And this shows across the map of the US that there are multiple sites, particularly among rural areas in many states, where HIV prevention services do not exist and where travel time represents a barrier to getting a PrEP prescription or seeing a PrEP provider. And so this also shows that the distribution of PrEP providers may be a challenge to individuals accessing PrEP. Now, one of the important things that I need to mention again about PrEP implementation are that it's beginning to recognize for those who have implemented PrEP that there's significant rates of discontinuation of PrEP that are very concerning. And there are factors that contribute to discontinuation rates. These include the type of insurance individuals have. And so if you look at the figure on the left, you see that there are higher rates of discontinuation of PrEP relative to other types of insurance for those who have private insurance. So for example, in this study among a Los Angeles county, they found that individuals who had PrEP prescriptions were more likely to fall out of care compared to those who had state insurance. Similarly, individuals who had to pay out of pocket for PrEP prescriptions tended to drop out of PrEP more. So it's increasingly being recognized that access to PrEP, financial access to PrEP, being able to afford not just the medications, but also clinic visits and cost of laboratory tests is a significant barrier to people retaining on PrEP. And the disheartening news is that the greatest amounts of discontinuation in this study were found among the youngest individuals aged 18 to 24, which again represents the risk group where HIV incidence appears to be increasing. Similarly, another disheartening news about this was that individuals who discontinued PrEP but who maintained indications for PrEP, that there were actually HIV seroconversions among those groups. So PrEP discontinuations have a cost, and sometimes the cost is individuals acquiring HIV infection. And so efforts to not just initiate PrEP, but to ensure that individuals who remain at risk of HIV stay on PrEP is critically important. Now, we talked about some disheartening things, and now this is a ray of sunshine talking about some good news with HIV prevention. So one of the interesting things around the rollout of PrEP, for example, this is looking at incidence trends for HIV diagnosis among people in San Francisco over a decade from 2006 to 2016, looking at incidence trends in San Francisco. It was very interesting to see that if you look around 2012, 2013, where PrEP was implemented and begun to be rolled out in those communities, with coverage rates among men who have sex with men in those communities sometimes as high as 50%, you can see that between the 2012 and 2016 timeframe, there was a 51% reduction in HIV incidence. This is very encouraging. Now, this is at least, indirect evidence that HIV pre-exposure prophylaxis can lead to declining HIV incidence, as it appears to be the major public health intervention that occurred around that time frame. Now, as I mentioned, the only approved drug for HIV pre-exposure prophylaxis is tenofovir disoproxil fumarate and emtricitabine. We know that a large worldwide clinical trial is going on for tenofovir alafenamide and emtricitabine combination. That early indicators from data presented at the CROI conference in 2019 suggest that it may be non-inferior to the FDA-approved drug. However, it is not yet approved. So, but there are so many clinical trials in the pipeline looking at both different modes of delivery of prevention medications, injectables, implants, long-term oral agents, and these are all in clinical development. And so it is anticipated that in the future, the HIV prevention pipeline will be quite robust, where individuals would have multiple prevention approaches that they can choose from that adapt to their lifestyle and tolerability. So I'm going to end this presentation by giving you some pointers on how you can implement PrEP within your clinic, within your health system. And it's critically important because we know that there are about 1.2 million individuals in the country who are engaging in risk behaviors for HIV and need to be engaged in HIV prevention services. All hands must be on deck to ensure that prevention services are available to those who need them. Now, one of the huge problems that have been described that has impacted PrEP implementation is that the individuals who should be providing PrEP do not know about it. So it's estimated that about 1 in 3 primary care doctors and nurses haven't even heard about HIV prevention strategy, and that's really, really concerning. And when it was looked to see what the barriers to prescribing PrEP were among providers, there were common complaints where concerns around if insurance would cover the medications, individuals felt poorly trained to prescribe PrEP or were uncomfortable with antiretrovirals, and some were not even aware of the CDC guidelines or cited time constraints in the patient interaction to discuss HIV prevention and offer it. So I would like to highlight what I think are the important considerations around who should be providing PrEP. I strongly recommend that HIV prevention does not need to stay in the domain of the infectious diseases provider world and HIV providers, and that individuals who are engaged in primary care, be it in internal medicine, obstetrics and gynecology, pediatric programs, should really be engaged, should be brought on board if we are going to implement PrEP on a scale that would impact the HIV incidence in the United States. And so for primary care individuals, certain advantages that they have are that they interface with a heavier traffic or higher volume of at-risk HIV individuals. Individuals in primary care tend to have a preventative mindset with use of vaccines and cancer prevention approaches, such that introducing prevention modalities for preventing an important disease is not entirely novel in those settings. And many of these providers have very long-term, longitudinal relationships with their patients. So to my mind, this represents very key advantages that the primary care provider population have with being able to interface with, identify, and provide HIV prevention services. On the other hand, infectious disease clinics tend to have pre-existing infrastructure to support, STI testing, for example, and to provide comprehensive HIV care and also resources for HIV prevention. And so I think that everyone has something to bring to the table to support providing risk assessments and implementing pre-exposure prophylaxis, whichever category they belong to. So this is to show that the CDC released guidelines in 2014, which are updated in 2017. These are freely available on the web, and I would strongly recommend them for review and adapting to your local setting for those who are interested in implementing PrEP within their programs. Now, the CDC guidelines suggest that there are 3 risk groups that should be targeted for HIV prevention. These are men who have sex with men, heterosexual women and men, and injection drug users who engage in risk behaviors for HIV infection. And so, for example, for men who have sex with men, being in a serodifferent relationship, having a recent bacterial STI that suggests poor rates of condom use, having high number of sexual partners, and engaging in exchange of commodities for sex should raise red flags among a provider that they are engaging in HIV risk behaviors. For injection drug users, sharing any equipment or paraphernalia, or even having an HIV-positive partner should remain red flags. So in some of the subsequent slides, I'll be showing you ways in which you can elicit these risk behaviors by asking the right questions And I will say that your yield of getting the right answers to these questions will be optimized if you ensure a confidential environment, if we're comfortable with taking a risk assessment, history or sexual history. And these are critically important skills that providers must have to be able to elicit these risk behaviors and identify individuals who need further counseling about HIV prevention. So an example of what it looks like is presented in subsequent slides. However, I want to make one point before we go into the detailed questions. We need to remember that patients do not readily disclose their sexual behaviors to their healthcare providers. So it's important for us as provider communities to engage these individuals and ask the questions and not depend on our patients to volunteer this to us. And we need to be comfortable with asking questions around sexual orientation, such as, do you have sex with men, women, or both? What kind of sexual practices do you engage in? What are the number of sexual partners you've had, usually within a time frame, 3 months, past 12 months? And how well do you utilize condoms? And also to elicit histories around substance use, which increase sexual risk behaviors. So I am not going to go through all these templates, but I think that for the different risk groups for HIV, asking important questions around who individuals have sex with, which gender they do have sex with, the utilization of HIV prevention strategies such as condoms and how frequently that is done, and also inquiring about having partners who are HIV positive and HIV disclosure rates. These allow for identification of individuals, whether they be men who have sex with men or heterosexual men or women, around their HIV risk. So if these numbers are applied correctly, the estimates by the CDC are that 25% of men who have sex with men aged 18 to 59 years of age will meet an indication for PrEP. Similarly, for heterosexually active adults within that same age range, about 0.4% will meet indications for PrEP. When you look at the estimated numbers, that comes to about 492,000 men who have sex with men and 624,000 heterosexual individuals across the US, adding up to 1.2 million across all risk groups who are currently at risk for HIV and will benefit from HIV prevention approaches. So my suggestion would be that even for other risk groups, for example, individuals who have an active sexually transmitted disease, especially the bacterial STDs, individuals who've come to the emergency department or your clinic for non-occupational HIV post-exposure prophylaxis, and people who inject drugs should be evaluated for pre-exposure prophylaxis as the standard of care. So for providing PrEP, you want to determine clinical eligibility. Very important to confirm HIV negative status, but also to confirm the hepatitis B status and that they have a creatinine clearance greater than 60. The latter two considerations are because tenofovir and emtricitabine also treats hepatitis B and can also cause renal dysfunction, such that having a robust renal status would be important prior to initiating the medications. For those who are Hep B positive, it does not represent a contraindication to tenofovir and emtricitabine, but those individuals need to be counseled about the risk of rebound hepatitis if they discontinue the medication inappropriately. You need to educate people who are going to start PrEP, as you do for every medication that you start in your patients, on the side effects of the treatments, the limitations of PrEP, need for daily adherence, the symptoms of HIV seroconversion, and the criteria for discontinuation. Also, the social determinants of health and things that could interfere with medication adherence, such as concomitant substance use or active mental health, also need to be addressed. Remember, we talked about not just initiating people on PrEP, but we talked about the data around people staying on PrEP. Now, for those who meet clinical eligibility, who are typically HIV negative and have a creatinine clearance greater than 60 and are engaging in risk behaviors for PrEP, you want to provide a 90-day supply of PrEP to them. And for those, some individuals may require insurance prior authorization. And some of the codes that we use in the clinic setting are exposure to HIV, exposure to HIV. It's important to mention that there is a medication assistance program for individuals who cannot afford their copays or deductibles to the total amount of $7,200 a year that's offered by Gilead, who manufactures the medication. Now, when the patients return to you every 3 months, you want to assess them for acute HIV infection. Generally, we utilize the 4th generation antigen antibody test and viral load. On occasions where there's been very recent exposure to HIV, we assess for side effects, both clinical and laboratory. Women of childbearing potential should have pregnancy testing, and STD screening should be performed for all these individuals at all orifices where they could have been exposed to HIV, and the prescriptions renewed. At least every 6 months, creatinine clearance should be assessed, and also at least annually you want to assess the need to continue PrEP for these individuals, which means conducting a revised risk assessment. So let me round up this presentation by summarizing that the HIV incidence in the United States remains quite high, disproportionately impacted young individuals and men who have sex with men. And similarly, PrEP implementation studies have shown that those risk groups also are not as engaged in PrEP as they should, and so much more work should be done. So what we can all do is, for every patient that we encounter in our clinical practices, we should perform a sexual risk assessment to identify individuals who engage in behaviors that put them at risk for HIV infection. We can counsel them, including providing data about HIV PrEP, and we should either prescribe PrEP within our clinical settings or refer individuals to a PrEP provider. Now, there are resources which I think are critical. There's a list of PrEP providers that are maintained by the Department of Public Health, which is available online, and here's a link to that PrEP list, such that you can refer patients to providers that are listed on there. There's multiple patient information portals. I've just listed one of them that's local to us, and also the PrEP Guidelines website that can be accessed. I just want to acknowledge colleagues who have contributed to this presentation, and the names of the organizations are listed, and more importantly, the PrEP clients that have added to my engagement and knowledge on this subject. Thank you.